Welcome to this edition of Platform. My name is Muhammad Kudu Abubakar. Diabetes, in a layman's language, is described as a disease or medical condition caused by a lack of insulin, which makes the patient produce a lot of urine and feels very thirsty. Experts say diabetes is now a worldwide epidemic with far-reaching devastating consequences, especially among blacks, particularly Africans. This edition of Platform discusses healthcare management in Nigeria and the diaspora with a special focus on the global epidemic, diabetes. Our guest is a medical doctor with extensive broad-based training and clinical expertise in more than 3 continents. Dr. Nelson Aluya is currently the medical director at Newark Extended Care Facility, New Jersey, the United States of America. As an assistant professor of medicine and pediatrics at the Rutgers University Medical School, New Jersey, Dr. Aluya has had vast knowledge in the medical management of people of diverse social, racial, and ethnic backgrounds with varied medical concerns. He graduated from the Ahmadu Bello University Zaria with a degree of Bachelor's of Medicine and Bachelor of Surgery, MBBS. He had his internship first in Nigeria and thereafter proceeded to the United States for another internship in medical pediatrics postgraduate at Newark Beth Israel Medical Center in New Jersey. Dr. Nelson Aluya is a Nigerian diasporan based in the United States. He will also tell us how Nigerian doctors in the diaspora can contribute to bridge the huge gap in Nigeria's healthcare system. Dr. Nelson Aluya, welcome to Platform.
Thank you very much. It's a pleasure.
As usual, on the panel, we have a distinguished appearance of one of our very seasoned health television producer, Moji Makanjola.
Thank you very much
And
for
of
having
course,
me on.
joining her is our health correspondent with the NTA News 24, Aisha Ubali.
It's a pleasure to be on Platform.
Yeah, it's a pleasure for all of us that we have a diasporan medical doctor here in Nigeria with us to discuss health management in Nigeria and specific issues of diabetes and several others. But Dr. Nelson Aluya, before we really start, in the introduction, I talked about the fact that you did an internship in Nigeria. Then you went back to the United States to do internship and you never came back. How did it start, or where did it start? What happened? Let's start with that.
Well, as you said, I trained at the great Ahmadu Bello University, Zaria, and then did my internship there and further went to United States to improve on myself. The essence of it all is acquiring knowledge and skills and knowing the need to further expand your horizon. Those were the pushing force that led me to going to the United States. And I often joke with them in the United States. I said, listen, I came to the United States because it was the cradle of knowledge. If it was somewhere else, I would have gone there. For you to be among the best, you have to be where the best are. And that's why I chose the United States.
So what happens after the internship?
Well, I did further training in pediatrics and medicine, and then joined the university as well. And in the university, that's where knowledge as a whole can be put together and harnessed and pursue research and know diseases, at the same time impact younger individuals who are coming and teach them the full flow of how medicine ought to be practiced, how it ought to be viewed, and how to take care of patients and further expand yourself and your career as well. So and that's exactly what it was.
Go ahead.
Yes, okay. I'm just saying that it's wonderful to go seek for knowledge. And let's do a comparative analysis. What did you see there that you think you can bring back home? Or what is it that we're lacking here that we need to improve on in terms of acquiring more skills to do what we do at home better than we're doing now?
Right, no doubt. It's something I've always said. I got broad-based, extensive training in ABU. We were well trained. People say things have changed over the course of the years. Maybe or maybe not. But then going abroad, technology is a big issue. The approach to healthcare, it's another one. Policies that are set in place to make medicine comfortable are other issues as well. And even the empathy that's put into healthcare is another one. And then the medical legal reasons behind, you know, the healthcare and how you manage diseases is also of paramount effect. Over the years, unfortunately, I'll say there's a huge dichotomy within how medicine is in the United States and how it is here now. And the divide is fast expanding, unfortunately, I would say. When I went out there, there are things that I saw here, clinical conditions that I never, you know, knew what they were. I remember a case of a young man a close friend of mine who died of a heart disease here in Kaduna then. And when it was something that intrigued me. I wondered what it was. But over the course of the years, I found out that eventually he died of what they call non-compaction syndrome, which even over the years in the United States was not very well known. It's things that now they've delineated the disease and come to understand it even better. Why? Because people put work into finding issues and solving questions that they have, and then pushing on and trying to achieve and answer those questions. We have curious minds here in Nigeria, very bright, very intelligent young men and women who I have interacted with over the course of the years, and even when I interview them when they come for residency programs. But then, you know, when they have questions, the means to answer those questions is lacking. The technology, the resources to pursue and answer those questions are big issues.
Yeah. Okay, doctor, from what you've said, I think the caregiver gives to a patient is very, very important in managing whichever disease the patient has.
Correct.
So what are those things caregivers in Nigeria should do to improve on the way they handle patients?
Well, I look at it in two prongs. In the essence of it all is, you know, like I said, we were well trained when I was here. We were trained on the empathy of how to deliver healthcare. But then over there, it's a curriculum. Here, it's not, you know, outlined in a curriculum. And there are the principles and policies set in place by the government, by the state, by the institutions, and even the departments on how you approach patient care. Some of those things we probably do have here, but they're not, you know, emphasized on, or they're not enforced. That's one end. The other prong is the conditions by which people practice here. I mean, over there, conditions are well established. I mean, they make the doctors and those in the healthcare facility practice medicine the way they ought to, and they provide them with all the facilities and all the tools and you know the whole works that they need to do that. But here it's a big issue. Over the course of years, I've come from time to time giving lectures and talks, and I've visited emergency rooms, both in tertiary institutions here and even the federal medical centers and in private centers. We find out that the conditions where the doctors practice is a big issue, and those are things we need to address. I mean, I remember talking to a young lady the other day while I was at one of the federal medical centers. A friend of mine had fell off a bike and had a concussion. I was unconscious. The approach was not what I would do. The doctors I met, they were very, receptive to learning from where I stand and what I had to offer. And then, but then when I looked at the condition where they work, it was appalling. It's deplorable. It's disheartening. They work on tables that are, almost makeshift, or even platforms that are made of concrete. No fan. The place was hot. The mosquitoes all over, and the doctor who's supposed to work there for 24 hours is sitting with patients with mosquitoes swirling around him. I mean, you don't expect that kind of person to smile and be cordial.
So the doctor will, in the long run, also become a patient.
Yes, it becomes a patient.
So how do we bridge this gap then? I mean, you are up there. You are a Nigerian, of course. I mean,
right.
How do we bridge the gap between what obtains over there and what you have seen here?
I just want to add quickly to what Kudu has said so that you can deal with the two questions together. What you saw here before you left is not what you are seeing here today. Do you agree with me?
I agree.
Okay. So we have all agree here that we have a gap here.
Yes.
Right. Now, in closing this gap, is it just about the patients themselves, the environment, or even the medical practitioners themselves? Because we've had a lot of conflicting...
Or the facilities.
Or the facilities. Right. We've had the fact, you kept mentioning something that resonates to me, that, you know, a lot of empathy came with the training that you have here. And that is not exactly what is there, because you have rules and regulations that binds you to do some things. Right. So how do you marry all this together? You know, you brought a lot of things together here under this context of patient care and medical practitioners themselves, right, living up to STEAM. Right. How do we get this working? Can it work?
It can. I mean,
how?
It can. I think it's a work in progress, but it's something that would involve everybody, and at every level. I mean, from the patients to even the relatives, even to the individual department, the hospital, the state, the federal government level, and even the NGOs, and all the stake health holders, from pharmaceutical industries to those who supply medical supplies. Everybody ought to be involved. I mean, if you want to take it on a primary level from the patients itself, one, patients ought to and should be informed about health and health issues. And that's empowering them to understand their rights. They ought to have and to know their rights. And one of the issues that most patients have, issues they have here, most people don't know their rights. I mean, there are certain things that you should not allow happen to you. And if you feel uncomfortable about certain things, it's okay to ask questions. I mean, everybody's under some form of pressure somehow. Doctors are really pressed, no doubt. They work under, you know, huge duress, time, pressure, and space. But at the same time, you know, it's your right, it's your body. Like I tell my patients, I like, listen, I am with you maximum 30 minutes a day, you know, at a point in time. But you're with yourself 24 hours a day. So you know yourself more than anybody else will. So you need to know what and how you feel and how your body, if it changes, you need to ask questions. And then be bold. Ask the doctors questions. And that's one. But then again, you know, you have to find a way to ask. If you ask in a polite and decent way, obviously, you know, somebody will listen to you. Then, you know, with the healthcare, you know, aspect of it, the hospitals ought to have set principles, also guidelines, that which doctors ought to learn to practice, and then reinforce these guidelines. Not just reinforcing them, but also creating avenues where doctors are trained even better with this. Because, you know, with everybody else, you get one, if I say one thing one time, you get it. But not every one of us will get it at the same time. So you may have to repeat it, you may have to identify those who don't understand it, and those who have a difficulty understanding it, and then creating avenues for them to learn and to understand it even better. And that should go along everybody in the healthcare system. From the nurses to the doctors to even the family, the techs who take, you know, the blood, and the people in the labs. We all have a stake in this. You know, healthcare is an issue that
everybody has a stake. But speaking specifically now, you Nigerians who are up there are called diasporans. Right. What can you do? Because you're a big force, right, and you are even experts in your own right. What can you do? You have identified some of these challenges here, and you're a Nigerian. What do you think you can do to help maybe the medical institutions, the health centers, or is it the universities, or what?
Well, granted, you say we're a huge force. Yes, we are a huge force. There are over about 38,000 doctors practicing abroad.
Nigerians?
Yes, Nigerians alone. And we are not just doctors. As a matter of fact, I gave statistics recently. There are about 2.1 million Africans in the United States, of which Nigerians form over 46%. This currently about 440,000 of us in the United States alone. So it's a huge force. And everybody who I talk to, every diasporan, doctors or non-doctors, and then we talk about doctors, we forget others too. The pharmacists, there are lab technicians, there are physical therapists, there are physiologists, there are psychiatrists, and everybody else. Each and every one of those individuals have a passion wanting to come back, to give back to the society here. But one of the big issues that they complain about is the avenue, who to trust, how do we get it done? But I also tell people this. If you want to get...
you have done that through maybe NGOs that are based here in Nigeria?
Yes, but then the issue of trust is there.
You are not trusting individual now, you are trusting the NGO.
Well, even in the NGOs too, there are issues of trust.
Really?
Yes.
Well, I'm just going to come in here and say...
Because that's Moji's tough.
Yes.
She is in that NGO as well.
Yes, I know. I mean, when you're talking...
Dr. Aluya does not trust you?
No, couldn't have been talking about me. Couldn't have been talking about me because I'm in the process of advancing the media as a strategic tool for contributing to healthcare delivery system.
Right.
And you've just made some mention to that it's, I think that is an integral part of it. Information is powerful, is knowledge. And when you have information, you can as well use, looking after yourself starts from, what you talk about yourself. Now, but I'm worried, particularly about diasporans coming back home to give and to contribute. It's usually an intervention.
Right.
It does not last.
Right.
Take for example, you come in, you have surgery. Eye surgery is very one of the commonest that you have around.
Right.
How do you do with follow-ups?
Right.
Complications might arise. How do you do with follow-ups? So there's need for diasporans to trust and bring back knowledge so that you are not just coming to do an intervention and leave. And what happened to the complications? And I have followed up on some complications that have arisen as a result of our diasporans coming, that I'm happy about, that they do come, but that because they have to go back to their lives, the gap still exists. So how do we close this gap?
You see, my coming to Nigeria at this time is actually on a fact-finding, mission. If you have to, nothing good comes easy. You have to put your hands, roll up your sleeves, and put your hands in the dirt to get things done. One of the biggest concerns is, like you said, rightly said, follow-up and sustaining and propagating the things that the wishes and the values that people have. It's something I've thought about over the course of the years. I've done medical missions in the US. I do medical missions in Jamaica. And there's a structure that the Jamaicans have set, and the Caribbeans. Probably because they're so close to the United States, and it's easy for them to go back and forth. And I've done those things with them. I've seen how they do their things, and I want to be able to translate that here. So I recently met with, the Honorable,
Minister of Health?
Abike Dabiri, who is,
who's championing?
Yes, championing the diaspora, cause and all that. I mean, she's an amazing and a wonderful, receptive person. And I was really impressed, when I, tried to give within, even if it's within a short time, my dreams and ideas of what we need to bring. So my approach is this. First, we need to set up a constructive, firm structure of how the diasporans can come in and give back to Nigeria. in the sense that it has to be involved with all the ministries, the Ministries of Foreign Affairs, the Ministry of Internal Affairs, the Ministry of Health, where they ought to be a body that links and coordinates and collaborates this work with the people in diaspora, and then form a body also in diaspora. So even if it's NIDO or AMPA, which is the American, Association of Physicians, so that there will be body formed there. I've talked to some of the NIDO executives and the immediate past presidents, as well as AMPA. I'm involved in AMPA, and I'm also involved. I recently became the president-elect of New Jersey Medical Association. So it's a platform that I really want to use. There's so much to do. We can translate that into our consciousness here. So forming a firm, definite structure where people can account for, the things that they do. One, a body that would collaborate and coordinate each and every one of these things that's done. First, granted, people can come here to Nigeria to give effect, to do, but how do we know who they are or where they're even coming from? What's their expertise? If they're experts in those, fields, are they qualified to do the things they're actually doing? We don't know that, but we ought to know those things, because I don't want anybody who feel he's from diaspora or whatever come give here, medications or treatment to people, my people back home, when I don't know if they're really doing what they ought to be doing. And even when they come, what they're doing, is it applicable to national standards or international standards? Are those the things that we really want or need? That's one. The medications that come in, are they medications that are verified? Are they up to date? So those are things we ought to,
look out for.
To look out for as well.
So what was Honorable Abike Dabiri's? You said she was receptive, but what else did she say she was going to do? Did she tell you she was going to maybe hook you up with the Minister of Health, for example, or the other strata of health institutions?
Even before I met with them, there's AMPA has met with her before.
What is AMPA?
AMPA is the American Medical Association of Physicians in America. They're a collection of body of Nigerians doctors, not just doctors but physicians, dentists and psychiatrists who practice in the United States. So they've met and they're trying to form this same structure. But like with everything else, nothing is being done. But I have it as a passion. It's my driving force, because I think it's time we get these things done, because there's so much head needs and there's so much that can be done, that the system, that the people in diaspora can contribute to the system and help, like you said, bridge the gap.
Yeah,
so,
Dr. Aluya, let's quickly now veer into the other specifics. Sugar, diabetes, diabetes mellitus. These are, I understand, are different strands or kinds of diabetes disease that we have. And I understand it is almost becoming an epidemic. How bad is the situation? And what can people like you do? It's
very bad. I mean, if in 2016, the WHO and Center for Disease Control in America finally came to realization that diabetes is an epidemic. I mean, I've been sounding the alarm for the last 10 years in America because I see what it does to the black community. We, as a race, I tell people this, diabetes is new to us. In fact, studies have shown that in the 80s, there were just about 800,000 people who were known to have diabetes in Africa. But as we speak, it's about 19 million, and it's counting. So the incidence rate or the prevalence rate has quadrupled from the 80s to now. It's a big issue. If in America, where they have all the facilities and everything else, that the money and all that and all, they spend $440 billion on diabetes and diabetes-related disease. How much do we have in our entire healthcare system? As a matter of fact, less diabetes. So if it's an epidemic for them, to us here, it's a catastrophe. And it's something that we need to pay attention to. And that's one of the big issues and a passion of mine. And I think it's the alarm bell should be ringing in everybody's head. Because in the United States, 2015 alone, there were like 29 million people with diabetes, with 88 million with pre-diabetes. That's another portion again that we'll talk about. But in 2017, the reports for 2018 is not out. They're already from 29 to 33 million already. So 1 in 4 people in diabetes in America has pre-diabetes. So do we have those statistics here? We don't. And how many people do we have? We know in Nigeria that has diabetes. Some report as of 2012 said there were about 1.7 million. But we know that's a gross underestimate. So right now I'm sure probably over 3, 4, 5 million people.
That's speaking actually to those that have come out to report,
yes, those
or incidental findings,
right.
you know. But for me, we have an epidemic here, and it's a serious one. And when you are diagnosed with diabetes, you need some measure of treatment, and you can be on that treatment for life.
Right.
What do we do? Let's talk about the causes. What is it that makes us susceptible
For
now?
example, you said pre-diabetes.
Yes.
What is pre-diabetes?
Right.
What state is that, and
yes.
then what is diabetes?
Right. So the question is, why is diabetes an issue for us now, if it wasn't an issue before? Couple of reasons. One, our lifestyle. We're beginning to adopt the Western style of lifestyle. I mean, back in the days, I often say, if you wanted to see grandma in the next town, you walked, or in the next 2 houses, you walked. Now it's a phone. Grandma, how are you? And that's what it is. You used to walk to the store. Now we drive, or we send somebody. So obesity, it's a big issue. So our lifestyle, resulting in sedentary lifestyle, making us bigger. And, you know, unfortunately, the notion that the bigger you are, the healthier you are, is something we need to take out. That's all teaching, because the new teaching is you need to stay slim, you need to stay slim. But for me, not necessarily slim, but you need to stay active and fit. You need to find, if you have a lifestyle that's sedentary, you have to find a way where you have to exercise. You have to make your body move. So that's one. The diet is another issue. I mean, refined sugar. Everything now, you know, over the years I say is imported. We live on imported food, we live on imported stuff, and we see our kids are getting bigger and bigger every year. When they did the statistics, if you put the map of diabetes and obesity in the United States, they look similar. Do we have such maps here? We don't. So those are things we need to start putting in our consciousness. So a lifestyle, sedentary, food, those are big issues. In as much as it's inheritable. But however, if you don't provide the condition where diabetes will thrive, it will not thrive. Because we already had the genes, but it wasn't expressed. Now, before I come in, there's a new entity creeping into the medical lexicon. It's called epigenetics. Now, it's how your DNA expresses itself phenotypically. So, even if you don't have the DNA itself, but when environmental factors, you know, maybe viruses, the food you eat, and everything else, radiations, tend to change your DNA, it expresses itself in forms that manifest in diseases. Probably diabetes is one of them. So, what do we do? One, information, information, information.
That's where we come in.
Right. So, and that's why media, social media is a powerful tool. We know what the social media can do for us. So we need to blow this all out there. Because I'm sure in our lifetime, we will either one of us or know somebody or have a friend who knows somebody who has diabetes.
Now, what state is this pre-diabetes?
Right. So
what are the symptoms?
So if I may add to what Kudu asked, we know that diabetes can only be managed and not treated.
Right.
The pre-diabetes, can we treat it, or is there, what do we do to prevent it from getting to full-blown diabetes?
Right. Now, before I answer your question, diabetes has been with the Western world forever. It's new to us. However, the United States, when the declaration was made by WHO, they went a little further. They're not emphasizing on treatment just again, on diagnosis. They're emphasizing on pre-diabetes and diagnosing those who have pre-diabetes. And what does that mean? Meaning, there's those without diabetes. If you take a number, it's called the A1C, hemoglobin A1C, which is what the amount of sugar in your blood look like for the last 3 months. If you take that, less, if you have no diabetes, is 5 or less. If you have pre-diabetes, it's 5 or 5.5 to 6.9. So that's pre-diabetes. Now, if you have 7% or above, that's diabetes, with or without symptoms. Now, if you have 7, that's diabetes, until proven otherwise, plus or minus symptoms. But if you're in this pre-diabetes level, so before, because diabetes is a chronic disease, before you actually go on to becoming diabetic, a lot of people will be pre-diabetic for even 10, 20 years without knowing it. You may not have symptoms. Maybe once in a while you see you have visual problems. You begin to have, I can't read this that I used to read. Then the next thing you go get glasses. If you have that, go check your A1C. You have tingling in your legs. Those are early signs. But you're not peeing, because most people think, oh, if I pee all the time, that means I have diabetes. You may not pee. You could tingle in the legs. You go check your A1C. You find out you're pre-diabetic. If you're a male, you have sexual dysfunction. You may be pre-diabetic, you need to go check. So, and as a matter of fact, I have also been saying that in the United States, and I have every patient who comes to me for the first time, I screen them. I know what their diabetic state is. So I always tell people, if there's anything we're going to learn out of it here today, please, every individual, every Nigerian ought to know their diabetes status. And your diabetes status will determine whether you have no diabetes, you're pre-diabetes, or you're diabetic. Now, if you're pre-diabetic, then lifestyle changes, meaning watching what you eat. Refined sugar, you have to watch that. Exercising. You know, even if it's 2-3 minutes every day, it's the accumulative effect of those exercises that make a whole lot of difference, you know? And then, medications. For those who are really very, busy and struggling, they have problems, look, you can look for a dietitian who can help you, school you, because that's what they do. They'll school you, teach you the kind of food that is culturally acceptable to you, because everybody do not eat the same. And that's accessible to you. And then for those who can't, the medication metformin, it's an amazing drug. In fact, if you're pre-diabetic, take metformin. You could do, 500 milligram once a day or twice a day, depending on, what there's available or what you can manage. And then take the medication and then follow that up every 3 months. And then see if those numbers, if you're pre-diabetic with a 6.9 or 6.5, you put your metformin or you do the diet, you see those numbers. If you check 3 months again, those numbers will begin to creep backwards away from diabetes. And that's people I know who stayed pre-diabetic for 10, 20 years.
Okay. Dr. Aluya, let me ask, how often should we go for a check?
Okay.
How often should we do that?
Well, annual physical check once a year. Everybody should have annual physical check once a year. But then if you have problems with high blood pressure, diabetes, then you should follow up at least 3 months, every 3 months, just to check what those numbers look like.
So we have had the pre-diabetic stage, then the diabetic stage itself.
Right. I mean, diabetes affects every tissue in the body, from the brain down to the lower legs. From the brain, you can have strokes, Alzheimer's now, which is a big issue, being associated with diabetes. Big issue. Big number of people going blind. I speak to an ophthalmologist. He said, listen, I'm tired, of seeing people with diabetic neuropathy. I mean, even dentition. The dentists have issues, with people who have diabetes. And then, if you talk about the heart attacks, blood pressure. If you go on to the kidneys, #1 cause of kidney failure in the world is diabetes, followed by hypertension. And then if you have diabetes, it would even increase your risk of developing hypertension. So if you put those two together, we often call it a double whammy. So the risk of your kidney failing is even far more. Now, ulcers, amputations. In fact, one of the most disheartening things I saw recently when I visited one of the tertiary institutions was the number of amputations that were taking place. I mean, it was really disheartening. Those things can be preventable when you know your pre-diabetic state and then, managing it.
Well, quickly, please. I know that for diabetes, there's no age gap. They have diabetes in children, and I truly would like you to speak to this. It's important.
Right. There are various categories of diabetes. There's type 1 diabetes, which is the one where the pancreas, which is the organ that secretes the insulin, completely fails. For one thing or another, maybe genetic predisposition, the pancreas just completely fails. Now, those people really require insulin. Now, it can happen from as low as 3 months to, at any age, but usually for younger people. Now, there's type 2, which is the one that's, fast, growing now. And that's where that's associated with the, obesity and the lifestyle and everything else. And then there's a new entity that's coming out. It's called type 1.5. You have type 1, type 2, and type 1.5. And type 1.5 is, medically described as latent autoimmune diabetes of the adult, LADA. And how does that present? It actually presents like a type 2, but then eventually becomes a type 1. So because in people with type 2, it's not because you don't have the pancreas producing insulin. The pancreas produces insulin, but there's insulin, what they call insulin resistance. So the insulin is not getting into your tissue. Now, the beauty of everything the way God created it is for the brain. Thank God, you don't need insulin to get sugar into the brain. But for everything else, you need insulin. But the good thing is, the body, the muscles, take insulin and glucose when you move them. That's why exercising is paramount. I mean, you cannot overemphasize that. So with the type 1.5, it's because there's an immune response. Either because your DNA is exposed to a virus, we don't really know what is causing that, a virus, or even radiations that are coming up. So the pancreas begins to fail slowly, and there's increased resistance as well. So down the road, you begin with type 1, you take medication, they work, after a certain end, they can't work, and then you may now begin to require insulin.
Children.
Like the question she asked on
Children.
children.
In children, that's the type 1. That you definitely need insulin. How do they present? Most parents may not know it. I mean, once you begin to see abnormal weight loss, that's one of the early presentations. In fact, I remember a case I saw in my training here in Zaria back in the days. One of the early signs, the child was losing weight, and the parents didn't know why. Meanwhile, the child was eating. But they didn't, because it was such a child, it was peeing, and they didn't really know until they paid attention to it. And the child was peeing a lot, losing weight, eating excessively, but losing weight. So, and then if that continues for a while, you see them begin to get very lethargic, very weak. They're not as active as they used to be. And then if it continues, they may even go into coma. And those are early signs and symptoms that you can get. So in children, once you begin to notice some changes, child losing weight when you're eating, peeing a lot, you need to go see your doctor.
Dr. Aluya, I know that most people that are diabetic, you find them having hypertension as well. Is there any link? What's that link? Is it the drugs? What's causes the hypertension?
Well, because diabetes, like I said, affects every tissue, including the nerves. Now, the nerves and the vessels. So with every nerve comes a vessel, and with every vessel comes a nerve. They all go, hand in hand. And even those vessels get their own blood supply. So with people who have diabetes, there's increased risk of cholesterol. Cholesterol, what it does is it lines up the walls of the vessels, and they become thicker and stiffer. So the word is the compliance of the vessel. So for somebody who exercises every day, If you exercise, they're pliable, they're compliant. So if you have increased demand from the heart pushes, more blood, the vessels expand, and then, the demand is met. But with diabetes, it actually ages up those vessels, so they become really stiff. So on a stiffened vessel, a non-compliant vessel is a vessel that has a higher risk for hypertension. So they go hand in hand. That's why people with diabetes tend to have hypertension.
Now, let's go into other areas. Reading your resume, I'm told that your major research was in sickle cell management and transition in the primary care setting, utilization of antidepressants. What does it all mean?
Well, sickle cell is, I often say it's a black man's disease.
Again, a black man.
Yeah.
It's a black man disease. And unfortunately, historically, if you look back on the genetic description of diseases, sickle cell was actually the first disease that the genetic description was made. It was the first disease that was delineated. But however, from way back in 1901 till now, nothing basically has been done. Why? It's a black man's disease. So nobody, the Western world and everybody don't see any incentive to pursue research in that. And a few who do were actually done by white people. We have issues with resources and all that and all that. And that's why in my institution, I fought hard to see if we can set up a sickle cell clinic where people with sickle cell can come and feel at home and make it a medical home, a 360, healthcare for people with sickle cell, as well as, push the information out there for our people, the African Americans, people of African descent who have sickle cell, to be able to manage it, the disease.
Well, I must say here that Nigeria has something for the world, that is helping to manage sickle cell anemia. And I wonder if you have any information on nitrate. Maybe I'll give you that information when we leave here.
Right. It'll be of great help.
Yes.
Actually,
there's a medication that, is out there and has been in use for more than a decade.
Professor Wambebe,
yes. Who championed that. It's called Naprosyn.
Right. Okay.
It's called Naprosyn, and the institution, it's here in Abuja.
Oh, wow.
It's called Nitrate.
Okay.
And I think you need to visit.
Right.
And maybe the world is waiting for that, particularly particularly in America, where you have a lot of African descent.
Yes.
On sickle cell anemia. So.
Yes. Nigeria has, by report, has the highest number of sickle cell, in the world, and social, political, and even religious cultural, implications. That affect it. I tell people, I was talking to a young Indian lady, and they didn't even know they have sickle cell in India. Indians have sickle cell as well. The Hispanics also have a lot of sickle cell. But again, nobody's paying that much attention to it.
Because it's a black man's disease, right? So, okay, just like malaria.
So let's look at, even though I will want you to touch on the issue of prostate cancer and hypertension, then we can now look at the role migration or human trafficking plays in the spread or mitigation of diseases.
Prostate cancer is prevalent. It's prevalent among people of African descent, I must say.
Again, people of African
descent. Unfortunately, and with diabetes, once you have that, the chances of you dying is far more. Not to digress a little bit, if you take a global perspective of it, if you have diabetes in Africa, you have a 76% chance of dying. In America, it's 38%. In Europe, 24%. In South America, about 48%. In Southeast Asia, about 50%. So, for black people, every disease that is new to us, we have a higher risk of dying. For a couple of reasons. Either one, the epigenetics, because again, our DNA We do not know what these things are. So we haven't, over the time, metamorphosized enough for us to adapt to those diseases. That's one. Two, we don't have the clinical, financial, technical research and medications to mitigate those diseases. In fact, on the average per month in the US, it takes for you to manage diabetes $313 to manage disease in a month. How much does it take for us here? 2016, WHO said it was $212 to manage disease per annum in Nigeria. How many people can afford that? Now, if you translate that to prostate cancer, one, awareness is a big issue. Every male who is 40 years of age needs to get screened for prostate cancer. Every male who is 40 years of age needs to get screened for prostate cancer. Because for us, again, it comes in a little earlier. If you find out you have prostate cancer on an early age, you most likely will die from prostate cancer. However, the studies have shown that most men have prostate cancer even towards the end of their life. And if you take a percentage of men 80 and above, almost 70 to 80% have prostate cancer, but it's not going to kill them. It remains indolent. But if you have it a little earlier, the chance that it will spread is paramount. So, like we do over there, when Caucasians screen at 50, we screen at 40.
What are some of those symptoms? Maybe you just quickly tell the viewers know what are those symptoms.
First, I'll tell one of the ones that's easier for most people, that most men encounter. It's called benign prostatic hypertrophy, BPH.
You need to break it down.
Yes. Benign prostatic hypertrophy. It's the prostate. The prostate is a little, organ or tissue right above, at the end of, the urethra. There's a reason why God put it there. So as we grow older as men, it gets enlarged. It hypertrophies. Either because as we grow older, our testosterone that we produce naturally decreases. So innately, somewhere, it's trying to compensate for something. So it actually increases. So one of the early things that men have is you find out that you try to go pee, usually it just flows. Now you have to wait before it starts flowing. That's the early signs. And then when you pee, it used to go with a force. Now the force is not there anymore. It goes straight, and then when you finish, it's dribbling. You finish, you go, it seems as if, it's not there. You still have to go back. And then you have to wake up multiple times to pee. So those are early signs of prostate enlargement. It's called prostatism. So once you see that as a male, and you haven't checked your PSA level, which is the early screening tool for prostate cancer, your PSA, you need to go get screened. Because would that be prostate cancer? It's possible. But most likely, it may be just benign prostatic hypertrophy, just the enlargement. However, for prostate cancer, a lot of the time you may not know it's there. So for some people we've seen, the first sign they may get is blood in the urine. Any man who sees blood in the urine ought to go check a doctor. And especially if you're 40 years and above, you have to go see blood in urine. 2, back pain, unusual back pain. Because depending on what the cancer is, if it's at the top, it presents somewhere. If it's at the bottom, it could spread. And the early areas, it spreads to the bone and the bones of the back. So you may start having back pain, back pain. If you have back pain out of the ordinary, get an x-ray of the back and see if you have lesions in the bone, right? Or some may just come early signs, paralysis, both leg paralyzed. So those are early signs that may present with prostate cancer. So 40 and above, please get the PSA done.
Dr. Nelson Aluya, we can go on and on, but it's programs like this always have a duration, and we're about rounding off on that. Just very quickly, talk about this. I want you to emphasize the need for this strong structure that you're talking about that should exist in Nigeria for you in the diaspora to help the Nigeria's healthcare system very quickly, and then we'll round up.
And just before you, you answer that, I just want to give an information that the Federal Minister of Health has a diasporan desk.
Okay.
That, yeah, because you're a new president coming in,
Right.
I'm sure that will be able to help the collaboration you are going to speak to now.
Correct.
Right.
Right.
I think you may need to maybe give him a link to that. I mean,
Oh, sure. I mean,
so 2 links now.
two links, nitrate
and,
and
yes.
yes.
So,
We learn from each other.
Yeah,
every
so
time.
that's it. So we're all
Right,
stakeholders.
and that's what collaboration is all about. And that's my emphasis. We need to collaborate. There's so much people and so many people who want to give back, but they just have to know how to give back.
That's it.
So forming, attaching to NIDO, which is the Nigeria in Diaspora Organization, and the medical aspect of it, which is the AMPA, getting a center, a call center, that's what our job would have to be. And that's what the emphasis, I will go back to make sure we have a call center. So anybody in the United States who wants to have a medical mission done would be registered with that body and then would link it to the diaspora desk in the
So
Federal
that
Ministry of
makes
Health.
it extremely traceable.
Correct.
Yes, and then you will have counterparts here to work with.
Correct.
Yes.
And then the doctors here who want to volunteer, because it's a culture we need to start advocating for, volunteership, giving back. Everybody ought to learn to give back.
yeah, Dr. Nelson Aluya, Assistant Professor of Medicine and Pediatrics from the Rutgers University in New Jersey. Thank you so much for coming to Nigeria and for finding time to come to our studio on platform. Like I said, this is work in progress. We will continue, and of course, Moji Makanjola has also volunteered to also give you other links. So that's about that. And Timoji, thank you so much for...
My pleasure. Anything for health.
Yes. And Aisha Uba Ali, our health desk correspondent.
Thanks for
NTA
having
News
me.
24. Thank you for your thoughts and insights and your questions. Once again, Dr. Nelson Aluya, thank you for coming. The program is Platform, and we've been discussing diabetes, a worldwide epidemic, and also veered off into so many other health issues, prostate cancer, hypertension, and several others. And of course, the long and short of it is that Dr. Nelson Aluya is very, very disposed to bring him back the knowledge that he has acquired in the United States in the medical field, in pediatrics, in medicine, and several others, to come and bridge the gap here in Nigeria. And he is thinking, and along with several others, on how to construct and have a structure and platform that they can assist Nigerians' healthcare delivery system. That's Platform. I'm Muhammad Kuda Abubakar. Thank you for watching.